So just to stay on course, we're going to have our panel again at the end. We have a couple free questions, but while Saul sets up his talk, I'm going to introduce him. So Dr. Saul Priceman is an assistant professor in the Department of Hematology and Hematopoietic Cell Transplantation and associate director of translational sciences in the T-cell therapy program at City of Hope and the Beckman Research Center. Saul is, a card-carrying immunologist, and his research focus is on CAR T-cell therapy, and he has some of his therapies that are now in clinical trials, but I will let him tell you that part of his talk. And with that, Saul, the floor is yours. You were in presentation mode before.
I was and realized I was muted, and so
that's okay.
Figure out how to get back here. But hello.
Great to have you. Oh, you're on the bottom right. Go to bottom right where this. Go lower.
Sorry about that.
We can always cheerlead in the background, so
yeah.
There's all kinds of stuff.
Please do, Peter, because I'm in trouble here. I'm going to try again. Hold on 1 second. As you can tell, I'm an immunologist and not a computational biologist. Can you see my slides?
I could see your slides, yeah. Well, no, we could see if you have two screens, I think we could see, we don't see your, oh, there you go. Now we see it.
All right, wonderful. I don't know what happened, but thank you, Josh, for the introduction, and thank you to the organizers for the invitation. It's a pleasure to be here. And so I was going to go through and give you a little bit of a background on immunology in general and how we've landed on several modalities or therapeutics to target the immune system. And then get into what we're doing specifically in my lab and as an institution at City of Hope in terms of CAR T-cell therapy. And so when we think about therapeutic modalities, everyone will be familiar with surgery and radiation therapy and chemotherapy, and that includes targeted therapies. And in this audience includes things like Herceptin or tucatinib or other HER2-directed therapies, as well as others. And immunotherapy has really come on the scene in the last decade or so as a really viable therapeutic approach at not targeting the tumor cell directly, but rather evolving the immune system to see and target the cancer cells wherever they may be in the body. And so this has taken on several shapes. I'm going to go through them very briefly, and I'm happy to take questions, and I think these slides may be available at the end. But antibody immunotherapy is probably the oldest type of immunotherapy. And if you think of Herceptin, which is an antibody that targets HER2, an oncogene that's overexpressed in breast cancer, not only does it target the HER2 pathway to target a pathway in the cancer cells that's required for their survival, but also it engages the immune system as well. And that's done by a specific domain or protein segment on the antibody that engages immune cells that allow them to also target the tumor cell and cause cell death. And we've thought about cancer vaccines. This stems from all of our knowledge about vaccines in the field at targeting infectious diseases, and especially what we're doing now in terms of trying to get a vaccine for the treatment of COVID-19, as you all have been following the news as I have. But in terms of cancer vaccines, this started really in prostate cancer, actually, with a drug called Provenge, which took an immune cell, taught it that tumor cells were there and what they were, and then infused those in what's called autologous, meaning we took the immune cells from one patient, we trained those against the tumor cells in that patient, and then we put them back in, and hopefully those immune cells went around and found the cancer cells and killed them. And that was FDA approved, I think, in 2012. And then we generated more targeted therapies, which, as brutally as possible, took an immune cell, took a cancer cell, and forced them to come into close proximity. And these are called bispecific T-cell engagers. And that's shown here, and allows this specific immune cell we call a killer cell, a T-cell, to see the tumor cell and engage the killing capabilities it has when it comes into contact with a virally infected cell or hopefully a cancer cell. This is just a therapeutic modality, and that has been FDA approved now for the treatment of hematological malignancies or blood cancers, and is being tested actively in solid tumors, including breast cancer. And then checkpoint blockade, which is the idea that a tumor cell should be recognized by an immune cell. It probably is being recognized by the immune cell, but the cancer cell has evolved a way to shut off the immune system's ability to target it. And those are checkpoint pathways. It's the same pathway, and I could go into a whole spiel about this for another hour, but it's the same pathway that allows the resolution or the contraction phase of a normal immune response once you've cleared an infection. You don't want your immune system to continue going and going and going. You want it to shut down. Well, cancer cells is forcing the immune system to shut down. Those are checkpoint pathways. And we've found antibodies, and that's the royal we, that we've found antibodies and essentially release the brake on the immune system so they can go around and target those cancer cells. Again, that's very active in the melanoma space, a skin cancer, and has been FDA approved now for multiple disease indications, including most recently, I think, triple negative breast cancer. And so those are very viable approaches that we're looking at. We took a different approach, and this was studies that started in the early 90s and have matured over the last 30 or so years, where we've understood what T cells do when they engage a virally infected cell or a cancer cell. They should target it very specifically, but cancer cells have evolved ways to shut that down. We essentially built out a chimeric antigen receptor, which allows the engineering of a T cell in a way that can force it to see that cancer cell again. And I'm going to give you an example of that in breast cancer. I'm going to skip this video because I think I've talked too much. But to suffice it to say, this is a T cell in green targeting a tumor cell, secreting enzymes that literally pops holes in the membrane of the tumor cell and go on and do that serially. And that's something unique. We call it a living drug. It doesn't need to be infused over and over again. It's infused once, and the immune system grows out, hopefully, to target the entire cancer cell. This is the landscape of where we are with immunotherapies, and you can just see there are hundreds of early to late clinical trials that are testing all different types of therapeutic modalities, including cell therapy, oncolytic viruses, which I'm actually going to give you a little teaser about at the end, and other therapies that are re-engaging the immune system. And it started really with CD19, which is a protein that's expressed on the surface of B cells, another immune cell in your body, that gives rise to a lot of lymphomas and leukemias, which are very devastating hematological malignancies. The field built CD19 CAR T cells that target CD19 on those B cells, those malignant B cells, and get rid of them. And this is just a scan of a patient that was treated at City of Hope with a CD19 directed CAR T cell. This is the pre-treatment scan on the left. I don't know if you see my mouse. And on the right, 28 days later, one infusion of these CAR T cells eradicated disease all around the body of this patient. And we've seen that dozens of times now. And you can see in the table there, it's 100% responsive in these patients, which is a remarkable response. It's actually landed in the field in several FDA approvals for the treatment of heme malignancies in patients with quite staggering response rates. And these are heavily pretreated patients. They may have seen 5 to 10 prior lines of therapies, including bone marrow transplants, etc. So they're really on their last straw, and they come in and they have some remarkable therapeutic responses that can be durable in many cases. Our program has done very similar. This is a schematic we published 6 years ago now in the autologous CAR T cell world, where it starts as a leukapheresis, a large blood draw. We engineer those T cells to express the chimeric antigen receptor. We grow them up in dishes over the course of a week or two, and then at some point we administer them back into the patient. We've done this for over 200 patients in the last 4 years, spanning hematological malignancies all the way to solid tumors. And if you look in the middle in BBM, it's breast to brain metastasis, which I'll talk about today. And so there's a huge clinical unmet need. Over the last decade, there have been several HER2-directed therapies for the treatment of these patients. But really, at the moment, tucatinib, which just got approval several months ago, is currently the only approved therapy for the treatment of patients with HER2-positive disease, and as well as brain metastasis. And immunotherapy, CAR T-cell therapy in particular, has tremendous promise for the treatment of these patients. And because of that, we developed in our lab a HER2-directed CAR T-cell for the treatment of patients with HER2-positive brain and or leptomeningeal metastasis. And this was based on multiple preclinical or mouse data, and I'm showing that here. You can see the colorful blue, red, green spectrum, and that really just highlights the tumor cells growing in the body of a mouse, in particular in the brain, and we treated them with intraventricular delivered HER2 CAR T cells. So these are CAR T cells that we put into a catheter into the ventricle in the brain, which houses the cerebrospinal fluid in the brain or bathes the brain. And those T cells traffic to the tumor and eradicated disease in 100% of the mice treated. And this was very spectacular because when we did the same thing but gave the CAR T cells intravenously, systemically, at a 10-fold higher dose of cells, they were only able to cure 50% of the animals, suggesting that regional delivery for patients with brain metastatic disease may be the most viable approach. And we went on to show that these CAR T cells actually trafficked from the brain out to the brain to treat bone metastatic disease that was extracranial or not within the brain region. And actually, these cells were also provided to us by Patricia Stieg and one of the collaborations we've had. And we went on to show that intraventricular delivered CAR T cells cured all the brain metastases, as well as prolonged survival of the mice greater than intravenous delivery. And because of that and a number of other data, we started a clinical trial about a year ago in treating patients with brain and or leptomeningeal disease by intraventricular delivery of HER2 CAR T cells. This is a trial that's supported by the California Institute for Regenerative Medicine. But the major issue in solid tumors is this immune suppressive microenvironment. And it's a complex system. I'm showing this slide because it is a complex system. I'm going to shorten the point by saying that cancer cells don't like to be targeted by the immune system. They shut off immune cells, including CAR T cells. And we term this as immunologically warm or cold melanomas, which are responsive to what I talked about before, which is checkpoint blockade, respond pretty well because they're immunologically warm. There are already immune systems in the tumor cell waiting to be released. In the context of prostate, pancreatic, breast cancers, they're immunologically cold. There's not a lot of immune response happening in the tumor. And so they're much more difficult to treat, we've found, particularly with checkpoint blockade, but even with CAR T cells. And just a little teaser, there are oncolytic viruses. These are viruses that very selectively target tumor cells. And it's been used in the field to target many cancer cells because they selectively replicate in these tumor cells. They can cause cell death and immunogenic cell death, which actually spawns an immune response, not only to the virus, but to a tumor. And we've taken advantage of that. They also are vehicles that we can deliver genes of interest to the tumor specifically. And I'm going to tell you a bit about that. And TVEC is an FDA-approved oncolytic virus that's treating metastatic melanoma. And though it's promising, there are challenges with single targeting therapeutic agents, even including oncolytic viruses and CAR T cells. And we took this idea and we said, well, if CD19 is such a beautiful target for hematological malignancies and causes durable curative responses in patients with blood cancers, why can't we take a CD19 CAR and redirect it to a solid tumor? How can we do that? Well, we took an oncolytic virus, we forced it to deliver CD19 and infected tumor cells. Those tumor cells then express CD19 on the surface, and we could target them with a CD19 CAR T cell, making a tumor agnostic but very viable combination approach using oncolytic viruses and CAR T cells. We just recently published this work, and we actually showed that it worked very beautifully in mouse models. And this is just a beautiful picture, nothing like what Cyrus showed in the prior slide with vasculature, which was so beautiful to see. But this was just showing that these viruses can infect triple-negative breast cancer cells here and pop CD19 onto the surface. You can see that in purple. And those viruses did that very well, so well that they infected cells 100% of the time, presented CD19 100% of the time, but were only capable of killing 30% or so at specific time points. And we took advantage of that completely in showing that the combination, and this is a triple negative breast cancer model, which doesn't have HER2 on the surface that we can target with a HER2 CAR, very effectively was targeted by the combination of the oncolytic virus presenting CD19 and then CD19 CAR T cells. And this did more. It actually robustly increased immunity in the tumors and immune infiltration. And we're showing that here, and I'm going to skip, I'm probably over already. But what was most impressive about this is when we cured the animals of their tumors, we were able to re-inject new tumor cells that never saw the virus, never had CD19 on the surface, and they were blocked from growing, suggesting that not only we cured the animal of the primary tumor, but we induced what's called protective anti-tumor immunity. And this is long-term immunity against tumor challenge. So if we can think about recurrences following the curative response, this approach may be a viable way to actually durably cure patients. And we're looking at that very closely, and we'll translate to trial as well, because City of Hope has expertise, obviously, in CAR T cell therapies and CD19 CAR T cell therapies, but also oncolytic viruses. So as a conclusion slide, we'll learn lessons from our phase 1 trials. I'm just talking today about breast to brain metastasis, but our lab has ongoing trials in prostate cancer, a new trial to be started in the next couple of months in ovarian cancer, as well as pancreatic cancer. And we're addressing the major challenges that we see, including tumor antigen heterogeneity, which Dolores and Peter talked in terms of looking at liquid biopsies. And actually, I didn't mention, but we have a very beautiful collaboration with Peter Kuhn as part of our brain metastatic trial, which we're very excited about. And he's looking at circulating tumor cells in the cerebrospinal fluid in the brain of these patients. And we hope to learn a lot from that. And then I'll end. This is just a picture of my laboratory. Thank God I'm not wearing the same shirt today. And then this is my lab, our program, the T Cell Therapeutics Research Laboratories program, many collaborators of which Peter Kuhn and others are listed here, and the funding sources that have supported all of this work. So thank you very much.
Thanks a lot, Saul. Great data, great work. I mean, it's a great example of taking something from the lab bench side and putting it into the clinic, something that we all strive for.